Hello.
Hello.
Give me two
Oh,
seconds. I just gotta
take your
finish the thing.
time.
Got it.
Yes,
Okay.
I'm gonna turn off my phone. How are you? So good to see
Oh,
you.
it's so good to
What a
see you.
pleasure for me.
I love your background. It's beautiful. So,
Oh, in the common room.
tell me your like you're cool. Tell me about you.
You're so nice. I will tell you, I will fill in every and all blanks. Just really briefly, I came alongside the Perry community and founder Laura Crane a few years back and sort of wanted to expand I wanted to get educated myself as someone who's going through perimenopause. And I thought I can't be the only one. And certainly I wasn't. So I thought, wouldn't it be cool if there was sort of like a library of information available to the peri community and whoever stepped into it. And so I started having these conversations and they're wonderful and so helpful. And I'm just gleeful to have the time and that you have the time and we're open to speaking with us.
Oh, well,
Thank you
thrilled.
for that. Thank you for that. So I'm going to get us started because I know that you are on the clock as well. And we have so many questions that came in, and I'm just going to preface everything by just asking people to mute their devices. And I'm going to make sure that everything is quiet on my end. And if you have any questions, please do put them into the chat and I will facilitate them for you, Dr. Rubin, so that you don't have to worry about reading through the chat. So Dr. Rachel Rubin is a board certified urologist and sexual medicine specialist in the Washington, D.C. area. She's one of only a handful of physicians with fellowship training in sexual medicine for all genders. Dr. Rubin is a clinician, researcher, and devoted educator. In addition to being education chair for the International Society for the Study of Women's Sexual Health, she serves as associate editor for the journal Sexual Medicine Reviews. Recognizing the limitations in our healthcare system, Dr. Rubin launched her own practice in 2022 so she could provide patient-centered care with a multidisciplinary approach, working closely with physical therapists, sex therapists, and other medical and behavioral health providers. Dr. Rubin considers it her responsibility to educate other providers to ensure that they are armed with the tools to provide evidence-based, compassionate care to their patients. Welcome again, Dr. Rubin, to the Perry community. Thank you so much for being here. We're going all out on vaginal estrogen, and most of our questions have come direct from the community. However, I wanted to sort of frame us up with something that I don't think people realize. I certainly didn't realize that vaginal estrogen, and correct me anywhere and at any time if I get something wrong, but that vaginal estrogen can act as preventative care. So in that, I mean that we tend to think, I think most frequently about vaginal estrogen being a cure, if you will, not a cure, a something to help with vaginal dryness. However, and this is what I want to understand, if vaginal estrogen is preventative to other conditions like vaginal prolapse, incontinence, bladder function, urinary tract infections, can you give us those broad sweeping strokes?
Yeah, happy to. It is my favorite topic in the entire world. Just like we put sunscreen on to prevent future, cancers, we wear a seatbelt to prevent, a horrible accident. God forbid we're in an accident. Vaginal hormones is not just to make sex comfortable, although it does do that and quite well, but it's really there to prevent the tissue from getting thin, getting raw, getting irritated, which ends ends up allowing you to keep a healthy microbiome, which allows you to prevent urinary tract infections. It stops urinary frequency and urgency. It helps with leakage. It helps the pelvic floor to not be irritated, which can cause all sorts of hip pains, back pains, pain with pants, pain with sitting. So it is absolutely preventative. And we have to really change the paradigm. That's why I'm so loud and I never stop screaming. Every day I'm screaming because we've really historically, these drugs are approved for pain with sex. Right? Pain with sex. There's a lot of, people who couldn't care less about sex. And it's so funny because, yeah, I'm a sex doctor. I love talking about sex. I love talking about sexual health. But this is actually one area where I said, forget sexual health. This is about bladder health. This is about urinary health. This is about pelvic health. And that is so important that we empower our patients to understand that so they can advocate for themselves. Because what happens is they'll get prescribed a medication. They'll say, oh, it's actually my symptoms aren't that bad, or, oh, I just, I'll use it for a little bit and then I'll stop. But just like wearing your seatbelt, you can't say, oh, I did that for 30 years. I don't need to do that anymore. You have to keep wearing your seatbelt if you want it to keep working.
Thank you so much for that. That's so helpful. I think that to your point, the fact that vaginal estrogen is so often it walks through the door with the sex conversation. And so all of the other benefits are missed often. And that's what I wanted to get to. So thank you for answering that. Cream, ring, tablets. Are those all of the ways to utilize vaginal estrogen?
There is a pill as well. So yeah, we have a little bit of a toolbox. And what I always say is the best tool for you is the one you will actually use, which means that you can afford it, that you don't mind using it regularly and for the rest of your life. It doesn't bother you, irritate you, and you understand why you're doing it. So it's not a one size fits all. You'll hear a lot of me and my friends on social media talking about everyone should use this, or this is the thing to use. So I get a lot of questions about that, but it's actually very exciting. We have options and tools, because sometimes you'll start with one and say, ooh, that's irritating me, or my body doesn't like that, and you switch to something else. So I always say nobody fails vaginal hormones. And I say hormones instead of estrogen because we have an FDA approved vaginal DHEA product, which is lovely. So I'll use the term vaginal hormones because it's not all estrogen actually. And so I'll have patients say, oh, I tried it and I failed it. It didn't work for me. That is ridiculous, right? It works for everybody, and it's a lifelong therapy as a foundational product. So it's finding, now that doesn't mean each product works for everybody all of the time. Sometimes we have to tinker and tweak. I always say there's like expert level care when it comes to these issues, what we call genitourinary syndrome of menopause. And that's why I exist. But the basic entry level through the door that every primary care doctor, every gynecologist, every person, right? Even you could get it on telemedicine through, some online thing, is a basic vaginal estrogen or DHEA prescription, and start using it. You just got to make sure you're using enough of it. So it could be a tablet insert. It could be a cream, which the creams are the cheapest options that we have available right now without insurance coverage. It could be, a ring, which is, there's a lot of reasons, pros and cons for each one, but that's where, it's choice. That's really exciting.
Thank you for that. You just highlighted several things that I just want to circle onto and sort of hover around for a minute. I don't know if this is getting stuck in the minutia of things that don't matter too much, but for those of us patients who are walking into any clinician's office, should we be using language sort of with our clinicians and amongst ourselves that are we calling this vaginal atrophy anymore? Are we calling it? Yeah.
It's out. Vaginal atrophy is so out. Don't say it. It's not nice. For all my clinicians listening, don't tell a woman her vagina is atrophic. It is not nice. And most importantly, it doesn't describe the whole thing that's happening, right? And so it used to be called vulvovaginal atrophy. In fact, when I have a patient in my office and I have to code to her insurance company, we have to call it vulvovaginal atrophic vaginitis, which is not what it is, right? Because there is no code for what it is, which which is what we call genitourinary syndrome of menopause. Genitourinary, so the genitals, the urinary, syndrome of menopause. Now, it's kind of interesting because even non-menopausal people have this, so it's not even perfect terminology there, because there's some reasons why we may give therapy to someone not in menopause, but we call it GSM, genitourinary syndrome of menopause. Now, that doesn't mean the provider in front of you has ever heard the term GSM. And so this is a place where that's one of the reasons I'm so loud on social media. So you can go to your provider and say, hey, I've got urinary frequency and urgency. Sex is painful. Things are dry. All of a sudden, I notice my vagina. I've never noticed my vagina or vulva before from day to day, and pants are uncomfortable. I'd like to consider a vaginal hormone prescription. And the doctor may say, I don't know what you're talking about. Who are you? You're not Dr. Google. And then you could say, hey, watch this video on Dr. Rachel Rubin for 2 minutes on Instagram, and she'll explain it. And usually I can convince them, at that point. Yeah. So does that make sense?
It does. And it's so helpful. And I'm just going to pause this for a second just to ask everyone to mute their device. And I want to get back to, should you ever stop using vaginal hormones? And your answer sounds like an emphatic no.
Well, your body,
if you want to,
you get to do whatever you want. But I get this all the time. I have patients come to see me and they say, Rubin, you cured my pain with sex. Everything's so much better. My urgency, it's driving me crazy. I've got so much bladder urgency. There's something wrong. I think I have cancer. And we talk about it. And I say, oh, are you still using the vaginal hormones? Oh, well, I stopped it because you fixed my pain with sex. So I stopped it. So if you want it to keep working, you have to keep using it. And again, that's where it becomes important to find the product that is affordable, that is enjoyable, that is doable in your daily routine. We all learned how to do our skincare routine. Some of y'all skincare routine is much more intensive than mine is. You would probably be disgusted if you heard my skincare routine, but you learn the process, right? And so this is kind of similar. Your body, your ovaries will no longer produce hormones that keep the tissue healthy, strong, the healthy microbiome that can fight infection. And so you must use these products to prevent urinary tract infections, to not get frequency and urgency. I had a patient come in this week and said, I don't have to wear pads anymore. I drove for 4.5 hours without stopping to use the restroom. You have saved my life. All I did was give her one prescription and had her see a rehab specialist, a pelvic floor physical therapist, who are the heroes really of our community. And that was, so we make such a difference with something that is so safe. It is like one of the most safest medications that we've ever have in our midst. And we've had them. The craziest part, not to go, I know you have lots of questions. The craziest thing is these things have been around since the 1970s. This is gold, right? This is saving lives. This is saving people from dying from urinary tract infections. This is saving people's marriages. This is saving people from being able to sit and drive and live their lives and have their quality of life. And yet so few people are being even offered this, right? I sometimes wake up thinking, this can't be real. This can't be so easy. And yet it is. Here we are.
Amazing. Are there any contraindications? Should anyone be aware of that it's not for them?
So the only person where the medical community is still fighting and arguing, right, there's one person only, is the person who is actively on an aromatase inhibitor for breast cancer. And those patients, that's a big population and something we got to talk about. And do we definitely need more research? Now, I am a huge believer in that everything has risks and benefits, right? If you use an aromatase inhibitor, the side effects are astronomical, and you take it and you take on the risk of all the side effects because the hope is for no breast cancer recurrence. And so when you're talking about adding a vaginal hormone, there is some not robust data showing there could be a concern with recurrence, but not with death. And so that deserves a conversation. If a patient is on an aromatase inhibitor, we have a conversation. We often include their oncologist and we all talk together. We love the idea, we need more research. And that's again why I yell and scream. But everybody else, 99-year-old grandma, great grandma, lady who's had a blood clot history, lady who's had had a history of breast cancer in the family, lady on tamoxifen, transgender male. We're talking about a woman breastfeeding. I mean, there is nobody who doesn't benefit from these products when they have symptoms, of genitourinary syndrome of menopause.
Dr. Rubin, just to piggyback off that, someone asks, I thought that vaginal estrogen or vaginal hormones, I have to get myself in the habit of saying that, is not systemic, but localized. So why would that impact someone on an aromatase treatment?
And that's part of where we need more research. It
Okay.
is a local therapy, right? Usually within the first 2 weeks or so that you use it, sometimes the tissue is so thin that there's a little bit more systemic uptake. So I always say in that first 8 hours, your estrogen level could go, usually a menopausal person's estrogen is zero, like zero. The lab only goes to less than 5 or less than 2.5, but it's zero. And sometimes in the first 8 hours, we'll see a blip of your estrogen will go to 25. My husband's estrogen is 25. So that's, like a sort of a man's level of estrogen. And then it comes right back down to zero and it stays at zero. Now, we don't understand everything about these things. And so when you're on an aromatase inhibitor, you're really trying to make the estrogen level 0, 0, 0, 0, -0, if you can make it, to starve the breast cancer of any kind. And so there is a worry of adding, if you're trying to starve all of the body of estrogen, adding back a little local estrogen is maybe counterintuitive. That being said, can you afford not to take these vaginal hormones?
Okay.
Can you afford to not be able to sit? Can you afford to get urinary tract infections so bad you have hospitalizations and you're needing IV antibiotics? That's not good for your health and quality of life. And there is no data to show robust increased levels of massive recurrence or death or any worry on those patients on aromatase inhibitors. So it's confusing.
It's a personal sort of risk reward.
It's a personal,
decision.
right? Like
Yeah.
we all take on risk, right?
Yeah.
And so we have to understand that.
Okay, thank you for that. One more that's come here in the chat. Can vaginal estradiol cream break down condoms?
Not that we have any, that's a great question. Not that we have any data to show it. I don't know that it's been studied. I'd have to actually go back and take a look at that. Do you hear me okay, or are we frozen?
And then, can you give me a thumbs up? Oh, you're back.
Do you hear me okay? I'm so sorry.
Yes. No. You're back and you're
froze.
moving. Yeah.
So not that I have seen any literature on, there's no reason to believe that it would. That being said, I don't know that it's been studied. I'd have to actually go back and look. There are tablets, like vaginal tablets. There are rings, and certainly those wouldn't be a problem. And also, if you're using a vaginal cream twice a week, you can sort of time it so you use it after sex or something. But I've never seen any data about condoms, and I have no reason to believe that there would be an issue. But someone can educate me on that one.
Okay, thank you. Vaginal hormones. Here's a question that came in. Is it expensive? Are there over-the-counter options? Are they prescription only? Is there access to reasonable pricing anywhere? You mentioned creams being the least expensive, but can you put those two
right
together?
now, all you need is a prescription. It is not over the counter. So you do need a prescription for from your doctor. If you go on my website, rachelrubinmd.com, and go under blogs, there's like 3 blog posts that says how to get it cheaply, how to write the prescription, how your doctor writes it. And we're even doing a webinar later today that goes into it even further. We have 1,000 people signed up for this webinar, which is so crazy. And it's going to be clinicians and people, right? So that's, people are hungry for this information. So if you get a prescription for a tube of cream from your doctor, you can go to your local pharmacy with a GoodRx coupon. If your insurance should cover it. If it doesn't, then you could give a GoodRx coupon or go through an online pharmacy like costplusdrugs.com, which is Mark Cuban's pharmacy. And that tube is $20. And that tube of cream, you use a gram of the cream every day for 2 weeks, and then twice a week. That tube usually lasts about 2 months or more. So $20 a month, that means like less than $10 a month, you can use that cream. So it's really, when I got out of my training, 6 years ago, those tubes of cream were $400. Right.
Wow.
And so only within the last 5 years have we seen the cost. Viagra is like $8 for 90 days, right? Worth. If you took Viagra every day for 90 days, you're talking $8. Like, so
Incredible.
only in the last 5 years, and that has been from our advocacy online, yelling and screaming that people like Mark Cuban, y'all, Mark Cuban understands more about vaginal hormones
he really
than
does.
your
He
doctor,
does.
like than
Yes.
your doctor, which is
Yeah.
so crazy
wild.
that this
Yeah.
is, you know, because we're yelling and screaming because nobody else is.
Yeah, he's paying attention. Thank you for that. You mentioned the amount of cream that you want to be using or that you prefer that women use.
Yeah.
Can you speak to that for a minute?
Yeah, it's a little bit, you may hear, this is why it gets confusing, because you may hear people on social media say different things. And so here's the test, right? A lot of when I trained as a urologist, and many of my colleagues, and I do a lot of yelling at urologists because they tell patients, in my opinion, a little bit of the wrong information. They will say, or your doctor will say, ooh, just take a pea size of the cream, just a little touch of the cream and just dab it on the opening. And I have a problem with that, because if you check your vaginal pH and it's 4.5, which is acidic, that's where we want it, and it is 4.5, fabulous. You are doing the right thing. But if you're putting a little pea size on the urethra and your vaginal pH is still 7.5, you're not doing anything for UTI prevention. You're not doing anything. And so it's really, really important that we are using a dose that is actually fixing the problem. And so for some people, so that's why I say use a gram every day for 2 weeks. Some people may get that pH with a half a gram, right? I'm not there, but the point is are we fixing your symptoms? Is the dose enough? Now, it's not meant to be used every single day if you're using a cream, right? But if you have a ring, that is meant to be used every day. So it depends on the product a little bit. Does that make sense?
Okay. Yes, it's so helpful. Thank you. Thank you. Someone asked, or she said, I'm on an antidepressant and have lost my libido. The antidepressant is helpful to me though. Can I use vaginal estrogen and will this help?
So I love the question. So antidepressants can be wonderful and life-saving for depression and anxiety. It's not just like everything. It's not a one size fits all. If you have a product though, that's really helping you, that's wonderful, because depression and anxiety is really bad for sexual health, right? So, but there are side effects of some of these medications, and some of those side effects can be low libido, delayed orgasm. We don't see too much vaginal dryness or genitourinary syndrome of menopause, but likely the age is the thing that is causing that to happen. And so if you're having pain with intercourse or pain with intimacy, and you're having dryness and frequency, urgency, then vaginal hormones are going to be the cure for that. What vaginal hormones are not going to do is fill your gas tank of your libido and all of a sudden make your brain like, I want sex all the time, right? And so we work often synergistically of helping. Like, we have lots of medications, lots of psychosocial resources and education, lots of things that we do to help with libido. And we look at the whole person, right? We look at you from head to toe and say, what's going on with the relationship? What's going on with you? What's your medical story here? Sometimes it's whole body hormones, which is not the purpose of this conversation today. Sometimes it's medication that's non-hormonal to boost your libido that can work great. And we tinker, right? We get it right for you. And we see mind-blowing results, right? With people even being able to stay on their antidepressant medication. And so, yes, if you have pain and genitourinary syndrome of menopause, and that is why you're not interested in sex, sure, adding a vaginal hormone will make you love sex again, right? But it will not necessarily fill those brain receptors that are what sometimes make it more difficult for you to respond the way that your body did when you were a horny teenager.
Yeah, thank you for that, and for bringing up the biological, psychological, social sort of toolbox that makes the difference for everyone. Yes. Thank you for that. This is a sort of maybe a back to basics question, but I think just so important for people to understand. You can, in fact, take an oral estrogen and utilize a vaginal hormone simultaneously. Yes.
There is no question too basic. And it's really important that we dig down on all the details, because for everything I say, 20 questions come up that I don't even think of. So there's whole body hormones. And then there is local hormone therapy, local hormones for genitourinary syndrome of menopause. And they're kind of separate. And what we find is whole body hormones, so hormones for hot flashes, night sweats, osteoporosis prevention. Those hormones, whether it's a patch or a pill, or those hormones often aren't enough for the genital and urinary symptoms. And so adding, remember we said local therapies don't increase your blood levels.
Right.
So adding a local therapy to a whole body regimen is not at all dangerous. It doesn't increase your risk at all. And it is often necessary. Now, so what I'll do, I do have some people where it's enough. Their patch is like fine. They have no symptoms. But every time I see them every 6 months for refills, I'm like, really? Are you sure? You're not having any frequency? You're not having any urgency? Because adding a therapy is not adding any danger. Now, again, if you want to get into the minutia, and sometimes we confuse people when we get really high level here, one of a product, right? So for whole body hormones, there are patches, there are creams, there are pills. There's also a ring. There's 2 types of vaginal rings, just like birth control rings. You kind of set it and forget it. There is a local vaginal ring called an E-string, which goes in for 3 months at a time, and it stays local, right? It is local therapy. It won't help your hot flashes, your night sweats, your bones, but it will help prevent urinary tract infection. The E-string, that ring, is great for a woman who's got poor dexterity, who can't do something twice a week. Maybe a lady in the nursing home who, needs a little extra help. Great. But they also make a ring called a ring, which stays in for 3 months at a time, and it's a high dose. So it's enough for your hot flashes, your night sweats, your bones. And so it's really important, if you're using whole body hormone estrogen, you need progesterone to protect the uterus, because high dose estrogen can grow the lining of your uterus if you have one and lead to uterine cancer, which is bad. We don't want people to get uterine cancer. But we found, right, since the 70s, we've known that if you give progesterone with the estrogen, that risk goes away. And so this is where it's important to understand the difference between local therapies, whole body therapies, and it's not a one size fits all. In fact, the risk of taking a pill of estrogen is very different than the risk of using a patch or a ring. Right. And so again, it gets the more I can get patients to listen and learn and ask questions, then these light bulbs go off. And so I empower women and say, don't do hormone therapy because I tell you it's a good idea. You need to do it because you've read about it. You've learned about it. You've listened to podcasts. You've read books about it. You listen to Kelly Casperson on social media. You listen to Heather Hirsch on social media. You listen to Fenwa Millhouse on social media. Like, you're learning. And then you come to me and say, Rubin, I understand the difference. I understand this. I understand the risks. I have a question about this. That patient does so much better. Always does so much better.
I love that point. Just to drill down on this for a second, that getting educated makes all the difference. It's clearly empowering, but it also just helps you understand yourself, helps you understand what you might want to try, helps you understand, right? Yes.
So I have this crazy new idea and I'm passing it around. I want you to tell your friends. Yeah. I have learned over the past years of doing this, I have learned that if you give people, particularly women, because I treat everybody, but particularly if you give people information and knowledge, they make excellent decisions for themselves and their own healthcare. It's crazy.
It's a crazy idea.
It's a wild unbelievable idea. I have seen it over. I've actually never seen it not work. I have never seen anyone make an awful decision for their own body and their own healthcare when you give them adequate information. Now that's the problem, the adequate information. There's not enough time in the doctor's office, and there is so much garbage out there that is just giving you god-awful information, which is again why I feel the weight of the world on my chest of like trying to answer all these questions, trying to do the best that we can. And here's the other part. We don't know everything, right? Sometimes we sit on the edge and I have to tell a patient, here's what we know. Here's what we don't know. Let's make a really good decision for September 1st, 2023. Exactly. And then next week, if something comes up, we'll talk about it.
We're going to revisit it. Thank you so much for that sensible, practical approach to medicine, to patient care. Moving on. Will vaginal hormones trigger yeast infections if you are prone to them?
Love the question. Actually, very important question. So remember, when you are starting a vaginal hormone, your microbiome is crap. Your pH is high. It is not acidic. The goal of the vaginal hormone is to acidify the tissue. I just saw a woman yesterday. When I saw her 3 months ago, her pH was 7.5, which is the highest my scale goes. She was having awful symptoms. She came in, she was having pain-free sex. She was having lubrication again. She was not getting UTIs and in 3 months. She was so happy. And I checked her pH and it was 4.5, which is what it should be, right? The acidic nature. So in that process of going from 7.5 to 4.5, occasionally, right? Occasionally, not with everybody, we'll see a yeast infection pop up because yeast tends to like acidic environments. However, I will tell you what the answer is don't, if you get the yeast infection, don't immediately panic and stop the vaginal hormone.
Sure.
Keep going, right? Keep going because the microbiome tends to figure itself out. Takes about 2 to 3 months. So what I tell my patients is if you get a yeast infection, call me, we'll swab you, we'll throw a diflucan your way, but keep going. And I will tell you, I've been doing this a long time. I do not have a huge population of recurrent yeast formers. Okay, I don't. Their bodies figure it out. I do not have patients on some of these newer medicines that is like wildly, like there's some cool new yeast infection medications. That being said, I know these people exist. I know patients do get chronic yeast issues. So what I would say is you have to give it that 2 to 3 months and keep going. And if you are one of those chronic yeast people, you got to work with a high level provider. You got to work with someone who is really trying to understand the whole situation, because just because you grow yeast doesn't mean the yeast infection is what's causing your symptoms.
Okay, thank you. This next question, forgive me, it came in late and I had to write it down. I didn't get to type it, so I need to make sure I can read my handwriting. I'm supplementing with vaginal hormones. Was on an estradiol patch, 75 milligrams, supplementing with Vagifem, and by day 5, I developed severe migraine. I stopped. I was told it couldn't possibly have been from that. Tried again a couple of months later, and by day 4 or 5, developed a massive migraine. It didn't resolve until I stopped the vaginal hormones. Have you ever heard of this? Does this sound normal?
So in my practice, I always say anything is possible and your experience is your experience. And of course, I love how scientific this person is and I love how they've experimented. And so we do get, right? I see the sensitive types. I see the weird and the wacky. Like this is why I do this at a very high level. And so that's a perfect patient of it's a little uncommon for us to see something like that, but this is her body, her experience. And so what we'll typically do in that situation is figure out a workaround. We may try vaginal DHEA, which would be a really good product for her. We may say, don't do the daily for 2 weeks, just go to twice a week, try it once a week and see what happens. I'm not worried about increased cancer risk. I'm not worried about, she's already on an estrogen patch. So I'm not worried about the level, but sometimes people have strange reactions to different things. There's the big data of what helps everybody. And then there's you, right? And you have to find a clinical provider who gives a crap about you, who knows you, who likes you, and who you have the know, like, and trust factor with. That's what we do differently, right? Is that we really and this takes time. And the really frustrating thing is medicine was not designed for clinical providers to get to know you very well. It's broken. We have a broken system. And so it may not be easy to find in your 10 provider who's going to spend 10 minutes with you who has no training on this subject. And so sometimes you have to, increase your team a little bit. I hope that makes sense.
It makes absolute sense and is so helpful. You've mentioned vaginal DHEA now a couple of times. Is that what? A non-hormonal?
Intrarosa. So Intrarosa, which is vaginal DHEA. So here's the story on Intrarosa. It is an FDA-approved product for genitourinary syndrome of menopause, just like vaginal estrogen. DHEA. Now you could go to GNC and buy DHEA as a supplement and take it by mouth. Our data by mouth is not robust. And so it's not something I use regularly or tell people to do regularly, but I know a lot of people do. But they found that if you take DHEA and you put it vaginally, the vaginal enzymes convert it into local estrogen and testosterone. So DHEA is the precursor of estrogen and testosterone. So enzymes work to kind of make it estrogen and testosterone. And what is fascinating is that your bladder, urethra, vagina, and vulva are swimming in testosterone receptors. So it's not just an estrogen story. And so it's actually, we do see patients, and there's some data that shows that if you don't respond to vaginal estrogen as robustly as we would like, if we switch you to vaginal DHEA, it can really,
That's amazing.
really help. Now, this is where the minutia comes in, and so if things aren't working for you, you got to see a specialist. But that is kind of the idea, is because the body needs testosterone. It's just that we can't even get people to talk about estrogen,
Right.
and yet women need testosterone too. And so
Right.
we got a long way to go. Now, the other problem with Intrarosa is that it's often not well covered by insurance. That my team has to do prior authorizations and be on the phone with insurance companies for hours to say, well, she tried the cream and she tried the inserts and she tried all these things. Can you please give her this thing that is going to work? And so there is no product like Intrarosa. And so it should be covered by insurance companies. It should be inexpensive. But here we are in America
Here we are in
in
America.
2023, and this is what we fight for every day.
Thank you for that. Progesterone, testosterone, no contraindications there.
For vaginal
hormones. Yeah. Somebody asked, I'm on testosterone. I take progesterone. Any contraindication?
No,
Good.
Totally separate issues.
You spoke about breast cancer. I'll skip to the next question. I'm still getting a period and using tampons. Is this okay? I assume not. She's assuming.
Yes. So that is, again, we give women birth control pills. Let me paint the picture here. Okay, everybody. Birth control pills are synthetic hormones, right? It's fake estrogen, fake progestin, not real stuff. You give it at crazy high doses to stop your body from ovulating so you don't make a baby. Okay. High doses of these things. Remember, vaginal hormones do not increase your blood levels of these hormones. So adding vaginal hormones to someone who is pre-menopause doesn't create any harm. Now, what is the benefit? We need more data, right? It hasn't really been studied at a high level. But we have lots of data to show if you have recurrent urinary tract infections, if you have urinary symptoms, you benefit from these products. And our guidelines in the urology world show that perimenopausal women, which means before menopause, really benefit from these products. So what I'll tell people who are still having periods and using tampons, like, you can skip your vaginal inserts and if you want to, like those times while you have your period, but there's no cross interaction. There's no problem. There's no danger. It might flush out if the blood is flushing out, but you're not going to hurt yourself. Does that make sense?
Yes. Fantastic. Thank you so much. Another breast cancer question, and forgive me, I am not learned at all. And so this person asks, is it safe to use vaginal hormones when you have a family history of maternal breast cancer? And I don't know if that speaks to.
It is safe to use
Okay.
So it is safe to use vaginal hormones safe. There is no data to show major harm. There's no data out there of any kind, and ever paper to say that vaginal hormones lead to death. They're zero. In fact, I challenge the internet. Find me a paper that show vaginal hormones cause death. Right? So there are no papers to show harm, whether you have breast cancer, whether you don't have breast cancer, whether you have a family history of breast cancer. There's no risk. And so, but the reward, the benefits are unbelievable, right? We have so much data to show benefit. And so you have to decide what is right for you. Here's the deal though. When you're in perimenopause, so we got to talk numbers for a second. Remember, I said vaginal hormones do not increase your blood levels of estrogen. When you are in menopause, your estrogen is 0. Okay. When you are pregnant, if you are pregnant, your estrogen is 3,000. Okay. When you're rocking around pregnant with an estrogen of 3,000, no one is chasing you saying, get that baby out. You're going to get breast cancer. Right? Get that baby out. No one's saying that. If you have a male partner, he's walking around with an estrogen of 25. Nobody's chasing him around saying you're going to get breast cancer. We need to suppress that. So it is not a black and white issue. It's not a clear-cut issue. And you have to really understand that it's not scary. This is not a scary product. This is not a scary medicine. Drinking a glass of wine a night is scary. Drinking a glass of alcohol a day increases your risk of breast cancer and breast cancer recurrence dramatically. Not exercising is dangerous. Not eating, gaining weight, smoking. These things are horribly dangerous, right? Vaginal hormones have never hurt a fly.
I'm starting to sweat. Thank you. This is like, I feel like I've gone to church or something. Okay. I've got another for you. I've been told that I have an orgasm disorder, and that makes me feel pretty crappy. Can you confirm this is even true? Can vaginal hormones help me? I don't know how much of my issue is psychological or what.
Oh, I'm sorry for you.
I
And
know.
here's the thing, orgasm is so important to people and should be important to people. It's important to my male patients. It's important to my female
Sure.
patients. And so if you are bothered by your lack of orgasm, you need to see someone who will work with you. And it's not an easy, oh, here you go, just take this fancy cocktail and you'll get,
Yeah.
cocktail, we're being a little funny there.
Yeah.
And then you'll have a magical orgasm. I got to figure out, have you ever had an orgasm? Are you trying the right way? Are you educated and understanding that penetration is not what leads most people to orgasm? Is it a medical problem? Is it a neurological or nerve problem? Have we not found the right device that might help you? And so vaginal hormones actually help with orgasm significantly, because as the tissue gets thinner and raw and irritated, that can delay and decrease orgasm. So if you are menopausal and you used to orgasm and you don't orgasm anymore, vaginal hormones is a great way to see if that will help improve your orgasm. And so there are lots of tools in our toolbox. They're not always an easy fix, but that doesn't mean it's not worth trying.
Thank you so much. Another question is coming on the chat. Any comment on the relationship with the use of vaginal hormones and the use of a Mirena coil for perimenopause? Would you still need an added estrogen patch?
So this is where the difference between local hormones and whole body hormones come in. So if you have a Mirena coil, which is an IUD in America, the wonderful British people call them coils. I love the British. I have this huge British following now, and I love it so much because British people are so much more educated about menopause than in America. They're so much farther along. So if you have a hormonal based intrauterine device, IUD coil, it is protecting your uterus, which means that you can take estrogen for your whole body, either in a patch, a ring, a gel. If you have symptoms, hot flashes, night sweats, osteoporosis, and you want that, or you can also use vaginal hormones locally. It's like either is fine, but you sometimes need both. Sometimes we do one, sometimes we do the other. And so again, I hope that makes sense. They're different products.
Dr. Rubin, I'm speechless. I feel like I just want to jump in your lap. It's just been an incredibly informative 45 minutes so far. Have I missed anything that feels pertinent to mention at this moment? Hello.
It's okay. I'm in my office. Sorry guys. Does it feel pertinent? I just want people to become educated. So follow us on social media. I'm at Dr. Rachel Rubin. Please get involved, advocate for yourself. If you're a clinician, join the International Society for the Study of Women's Sexual Health, or ISSWSH, ISSWSH.org. We do courses. If you want to hear me speak, come to our courses. If you want to learn more, come join us. We need you. If you're listening to this, we need your help. We have a lot of work to do. So I want you to follow me on social media or sign up for our newsletter on my website, because we have a lot of work to do. So the thing we didn't talk about right now actually is the big elephant in the room. Is when you pick up your vaginal hormone prescription, okay, the box has a big warning label on it that says it causes stroke, blood clots, heart attacks, dementia, and you must use progesterone with it. Remember, I just got done saying that none of that is true. You don't need to use progesterone when you use vaginal hormones. It doesn't go systemically, so you don't get a stroke or a blood clot or a heart attack or dementia. And I will tell you, women all read the box. I can't get men to read the box for anything, right? Viagra can cause blindness and they don't read the box, but everyone reads the box for their vaginal hormones. And every word on the box is a gosh darn lie. It's a lie. Okay, the box is based on false data, based on a birth control pill style hormone that we used to give to people. Okay, when you give somebody a birth control pill, they can get an increased risk of blood clots. Nobody denies that. Vaginal hormones and birth control pills are not the same thing. They're not even made up of the same thing, but the FDA requires the same labeling to go on them. And so we are killing women. We are killing women by putting these safety labels on the boxes that are false and harmful. And many women are not using these therapies. So there is a large group, a nonprofit called Let's Talk Menopause. We are gearing up to march on Washington to go to the FDA and scream and yell and shout until they change that box labeling. I don't care if I have to freaking, tie myself down to the front door of the FDA. So we need to create that change, right? And so it is a disaster, that labeling. It is hurting a lot of people, because if you get a urinary tract infection, it can kill you.
It can
right?
kill you.
It can kill you. So that's the big elephant in the room, where we need you, whether you are listening to this and you are an advocate, whether your partner works at the FDA, whether you work at the FDA, whether you know someone who works at the FDA, we need you in this fight to actually make real, meaningful change.
Thank you for that. And for mentioning this March on Washington event. We should all be on the lookout for that and make it if we can. Someone finally asked the best way to apply or insert the cream. You did speak to that a bit. If there's anything else you wanted to mention.
So I've learned myself on this one. Usually women don't love creams. They can be goopy, they can be messy, and they won't use them. I had an amazing colleague who taught this to me. And she said, oh, it's actually quite simple, really, right? You don't put sunscreen in 3 globs and just walk out of the house, right? You rub the sunscreen in. And so what she taught me was that if you take a gram and you put it on your finger, a whole gram, and you measure it out, you don't necessarily need the applicator. You just measure out what the applicator would have as a gram, not just a little pea size, but a whole gram of this stuff. And you can put it in the canal and rub the walls of the vagina until it is kind of completely absorbed in. And you certainly can take that extra pea size and rub it at the opening. It will not add any extra danger or harm. And so we typically do a gram every day for 2 weeks, and then twice a week till death do you part. So twice a week, you put a gram in, and you do that same amount at twice a week. And the reason we don't do more than that, or we don't do every day with the creams, is because our data on the blood levels being localized is on that regimen. And so sure, we need more data and we need to understand the safety, but if you have a uterus and we give you too much estrogen, and we run the risk of increasing abnormal cells in the uterus. So that's what we're always looking out for.
Dr. Rachel Rubin, thank you so much. What just an incredibly informative. We are all sort of uplifted with, information. Somebody says, thank you for your advocacy. Really, truly, thank you for the work that you do, but also ultimately the space that you sort of make for all of us as patients, as people who are not clinicians and do not have that sort of medical background, to say, we demand more, we expect more, we understand more now, and kind of walk in lockstep with you and others like you who are, changing everything for all of us, and for women's health, men's health in general. So thank you so much for your time. I know that you have an event you mentioned at the beginning. I don't know if anyone has time or if you're able to sign up for it now.
Yeah, since this is live, so you can even sign up on our website. Go to rachelrubinmd.com, go to the events page. You can click that first box there and register for, it's at 2:30, so it's in a couple minutes. We're going to do a half an hour all on this with myself and my partner, who you saw crawling on the floor over there, Dr. Claus. She didn't want to make an appearance. And we're going to answer these questions. We're going to show, here's the craziest thing is I've been talking about this topic every day for 5 years on social media. I put up for this webinar. It's a free 30-minute webinar to talk about everything I was just talking about, and I'll do it over and over and over again. We have 1,000 people signed up for this webinar.
The wave of this right now. Yeah, it's incredible.
And so I will talk about this all day, every day, and twice on Sundays. If it means that we are going to prevent urinary tract infections, that we're going to empower women to show up. Honestly, I was on NPR talking about this, and I got email after email from women saying, my husband heard this on the radio and he forwarded it to me right away. The men are listening. They are listening. They are helping. They're gently giving the information. Something is changing, and I'm here for it. And I'm just here to help empower people to know that there are solutions, that they don't have to suffer, that it's okay to give a crap about yourself and your quality of life. It matters. It should matter to you. It should matter to your doctor. And so I'm just grateful for the platform, for you bringing me on. And thank you for all that you all are doing for people and communities.
Thank you. Thank you so much, Dr. Rubin. I hope to speak to you again in the future. And everyone head over now to Dr. Rubin's website and log in for more of this. You're just phenomenal. A pleasure to speak with. Thank you so much. Thank you for everyone who came. Be well.
Thank you for having me. Bye-bye.
Thanks. Bye-bye.